Hello, friends. Welcome back. I just want to talk about a little bit about the osmolality gap and how do we calculate generally. This is of more importance actually in patients who come to the hospital with the alcohol consumption. In normal osmolality gap is the difference between what we measure in the serum, like in the blood, or and what is the actual calculated osmolality. You know, so when you're looking at the calculation, basically we're considering the chemicals which are normally present in our body. For example, we have salt in our body, we have glucose, and we have blood urea nitrogen, which is basically coming from breakdown of the uh, proteins. Now, the way I look at the formula, easy way to remember is the way I remember is that it's like plasma osmolality, something on the, let's say I'm sitting on the um, breakfast table. I have some kind of some salt on the table and then some glucose cookies in front of me and has some buns to eat, so I'm adding those up, salt plus glucose plus bun. Now these things like salt, glucose, bun, they contribute towards the osmolality. Those are osmotically active particles actually. So you can look at the formula: 2 times sodium plus glucose divided by 18 plus BUN divided by 2.8. So this is this whatever this is the normal osmolality. If somebody has somebody drank alcohol, then you need to add alcohol as well to this formula. So the osmolality will go up in those patients. So but the problem is when the osmolar gap goes higher in those alcoholic patient, is not going to tell us about what kind of subtype of alcohol the patient has consumed. It's just basically telling us about the some parent alcohol, not the metabolites of no, toxic alcohols. And there could be many reasons for like osmolar gap to go higher. Some common chemical like ethanol ingestion, like some toxic alcohol like methanol or ethylene glycol, diethylene glycol, propylene glycol, or some like like solvents like acetone, other chemical like diethyl ether or uh, trichloroethane. This can go up higher, like a smaller gap can go higher in patient having severe circulatory shock or hyperosmolar therapy when we giving mannitol or glycerol, like those are like osmotical particle. Basically, the thick things where like high viscosity, you adding them into the blood circulation, the osmolar gap will go up. Patients having chronic kidney disease or having lactic acidosis, salicylate ingestion, or if somehow if you the serum water amount goes down, or like the protein amount goes up, or the triglyceride amount goes up, all these things can lead to high osmolar gap actually. These are because those are osmotically active particles. In my next lecture I'm going to take some real patient, and I will do some like real calculations. Thank you for watching.